however many weeks into term, I was suspected to have spina bifida. So I had an amniocentesis. Well, I think about 4 to 6 weeks before I was born, my mum fell on her stomach. So already that's that freeze withdrawal reflex that's highly present.
Yeah.
Then when I was born, I was pulled out with forceps and they crushed my skull. So the whole right side of my skull was crushed, and you could see my left eye was protruding. I've always joked, I've shown people photos like held up next to Sloth from the Goonies.
Friends, welcome to the Decentralized Health Podcast and to episode number 15. Today's guest is a dear friend of mine. His name, Martin Fenn. Martin is known as the pain teacher. He specializes in pain, educating health professionals to blend neuroscience, functional medicine, and strength and conditioning to rewire pain, brains, and movement dysfunction. This podcast is going to blow your mind. The level of knowledge that Martin has in this particular field, which isn't spoken about that much, is phenomenal. You're probably going to want to watch this one a few times over. So sit back, relax, enjoy. Friends, welcome to the Decentralized Health Podcast and to Martin Fenn. Friends, welcome back to the Decentralized Health Podcast and to episode number 15. Today's guest is a very, very good friend of mine. This is Martin Fenn. Martin, how are you doing, brother? I hope you are well.
Yeah, I'm great, mate. How are you doing?
I'm beautiful, brother, and I'm really, really grateful for you coming on. I know it's late where you are for you, so thank you for taking the time to come onto the show. So for everybody that doesn't know who you are, please introduce yourself to the listeners and to the viewers, and then start your hero's journey wherever you see fit.
So I'm Martin, the pain teacher, and where that was born was out of a history of injuries from myself that no one could solve. So I kept getting repetitively torn tendons, subluxations, snapped tendons, tears, and no one could figure out why these patterns kept coming back. And this was also coupled with a childhood of like chronic gut issues, ADHD, autism, and it all culminated in me initially going into biomechanics for rehabilitation to try and resolve that. But after I'd been studying biomechanics for about a year, I realized the missing link was more neurology. So I started delving into the neurological side of rehab and correcting misalignments within the body, within the nervous system. At that point, I'd been studying neuro for about 6 years that I found out that I'd actually had a brain injury at birth, and it put all of the pieces together as to my symptoms, which was essentially where something called microglia, the brain's immune cells, become hyper vigilant to any small stimulus and then drive very specific focal symptoms depending on the region of injury. So mine had been hypersensitized from various traumas, the initial brain injury, well, at birth, and then subsequent illnesses, injuries, concussions throughout my early life. So then it culminated in all of these symptoms and gave me this clarity of picture. So it was very much born from having to figure out how to help myself. And then that developed into creating a system that blends functional medicine, functional neurology, more traditional strength and conditioning with, again, kinesiology, but the Eastern principles going into like TCM, Germanic New Medicine, from the emotional side of how that can impact disease states as well.
Wow, that's a lot to unpack, an awful lot to unpack. So for everybody listening, how me and Martin met was from the Institute of Health. We both went on there to study functional medicine, functional blood work, other lab testing and stuff like that. And that's when I realized Martin's brain was a very, very special machine, because the amount of knowledge that man can hold in his brain at one time is very impressive. And just over the last, what's it been now, 6 years or so, it's just got more and more full with the most incredible information. So let's start with how you treated yourself, in a sense of like, it doesn't matter about how the traumas came about or the head injuries or anything like that. How did you utilize the blend of what you had, the functional medicine, the neurochemistry, the biomechanics, the Eastern stuff as well? Because I love all that stuff, all the TCM and everything. Like, how did you start to piece that all together to create a program, so to speak, for yourself?
It's been a lot of trial and error, and a lot of the times over the years, I got the blend wrong. So I
Mm.
am a science experiment in my own eyes a lot of the time. So it's like it's hypothesizing based off research, and then how this can apply to my scenario, and then trialing and seeing, does that respond how I intended? Because that's one of the amazing things with neuro as well. There are rules and there are more defined pathways,
Mm.
but the order of synapses is effectively a culmination of someone's experiences. So no two people's brain maps are going to be the same.
Mm.
So the exercises that work for two people with the same symptoms are going to be vastly different because their brains have ended up in that way from a different journey. So it's very much just been trying to refine this understanding of what are the right inputs at the right moment in time.
Mm-hmm.
So how that sort of came about was initially with biomechanics, and then realizing some of these biomechanical issues were feeding the central issues. So it was a lot of like right-sided stuff going on. But when you start to understand the brain, then you start to see that, okay, every time I'm treating these tendon issues or whatever it may be on the right side of the body, all of that sensory information is coming into the left brain and upregulating that left brain, which in my case was already augmented because it was the right side that got injured.
Mm-hmm.
When you combine this with the concept of mutual inhibition, when both sides are working effectively, one fires, inhibits the other, that fires, inhibits the other side. When we've got an augmented side, so in my case, that left brain that was overactive, there's a permanent inhibition of that right side. So then the health of the two starts to drift further apart. So we get more of this functional disconnection, functional imbalance between the roles of the left and the right cortex. So every time I was treating that right side, it would augment the left and turn down the tone of the right more. So the early days, it was starting to then go like, okay, I feel better when I'm treating the left side of my body, even though this isn't the side that's hurting. There's got to be some reasons for this.
Mm.
Started to go into the neuro, and this got into primitive reflexes and looking at traumatic brain injuries and how they can disturb neurodevelopment. So a large part of mine was in the integration of primitive and postural reflexes,
Mm-hmm.
which effectively allows these foundational components of your reflexive systems to develop. Because when we're born, we can't volitionally move. It's purely reflexive based on the sensory information coming in that we then respond to, which then drives more sensory experience, which then turns on the genes that helps us build neural pathways.
Mm-hmm.
That is how our brains develop. And when we integrate these reflexes, we can then form these long-reaching connections that connect the left to the right hemisphere, and then come back down and inhibit these more reflexive systems.
Mm-hmm.
And this is like the foundation of our neurodevelopmental disorders, like our ADHDs, OCDs, ODDs, like autism, where these connections haven't been formed, and we don't then have that inhibitory response to the brainstem for the more reflexive systems. So that was a huge part, and a large part of that is actually sensory input. So you can see here that the room's illuminated purple.
Yeah.
Because I know we've had this conversation before as well, where I'm not a fan of blue light blockers. I know that's a controversial opinion, but when we look at the statistics that between 1 in 5 to probably more like 1 in 3 potentially now, people have ADHD.
Yeah.
Which is a disorder of a left brain that is augmented, a right brain that is turned down. So it's this functional disconnection known as a hemisphericity, where the right brain is in a state of hypofunction. Now, sensory inputs for the brain, light is a huge one because there is always light information entering our eyes. And the frequencies of light interact with the brain differently. So our reds, yellows, and oranges stimulate the left brain. Our blues, greens, and purples stimulate the right. So in those ADHD type, autistic, OCD people, having light that's coming in of the frequencies of red, yellow, orange can actually augment that side further and deepen the disconnection between the left and the right because it augments the left and turns the right down further. So then if we're using more greens, blues, purples to bring about an increase in function of the right, we start to get a bit more homeostasis and facilitate more of an integration of these reflexes when we couple it with the lifestyle components of supportive nutrition, of appropriate exercises, and then building on that as a framework to get deeper into our more cortically driven neural processes. So our learning, our volitional control of memory and so on, that's getting more like frontal cortex and building more into like brain games. But these reflexes form the absolute foundation. And I'll go into my history as that I had every single tested reflex present because I had at however many weeks into term, I was suspected to have spina bifida. So I had an amniocentesis. I think about 4 to 6 weeks before I was born, my mum fell on her stomach.
Oof.
So already that's that freeze withdrawal reflex that's highly present. Then when I was born, I was pulled out with forceps and they crushed my skull. So the whole right side of my skull was crushed and you could see my left eye was protruding. I've always joked, I've shown people photos like held up next to Sloth from the Goonies. So that's the before and after there.
Was the test for you to see if you liked Rocky Road? Was that what it was?
But yeah, one of the reasons I was such a trial and error in my application of neuro to myself is because of this injury led to a structural lesion in more than two, but keeping it simple, cortex and cerebellum on the right, which right cortex links to a region of the right brain cell called the PMRF, which regulates muscle tone on the same side. And then it also links to the cerebellum on the other side, which regulates the control of movement on the opposite side of the body. So we've got the right cortex initiating movement on the left cerebellum at the same time, clearing that up and reporting on errors. But we also have the right PMRF involved in that system. So that's the pontomedullary reticular formation, a region of the brainstem that regulates muscle tone on the right, because when I move the left side, I need to make sure I'm stable and don't fall over. We've got the same system parallel on the left. What happened with me is because I had an injury to the right cortex and right cerebellum, when we start to lose function of an area, that affects the other aspects of the network. So then I started to get functional issues of the left cortex, left cerebellum as well, because of that right cortex and right cerebellar issue. So there was a lot to unravel, and mine didn't follow the rules so clearly when you start learning things. So it led me going into all of the weirder applications and the things where like, okay, when do we actually have to break the rules a little bit? So I know I've probably gone on a few tangents already.
No, dude, we love tangents on this show. I love tangents because it opens up many doorways. The two that are, I know we've got a structure that I want to follow here because it's important, but the two pathways that have opened, just because I want people to understand what you're talking about here. The first one, which we'll pin for a second, is the primitive reflexes. I've only discovered this very, very recently through a friend of ours, Nicole, and obviously you know primitive reflexes anyway. So I had all mine tested and I had 4 of them still present. For people that, actually no, we're going to primitive reflexes now. For people that don't know what the primitive reflexes are, how could you simplify and explain that to them so they understand what we're talking about here?
So these are survival responses
Mhm.
built into the brain to allow a newborn to survive when it can't think or move volitionally.
Mhm.
So they are absolutely critical for survival, critical for brain development, but we're seeing more and more in modern life because of lack of movement, lack of sensory experiences, bombardment with electromagnetic frequencies. I mean, there's like walkers with iPads in them now, which is frying brains of
Wow.
infants
Mhm.
because their skulls are more malleable to EMF. So it's all of these things which impact, processed foods as well. So we're really looking in terms of primitive reflexes. They're essential for growth, development, survival.
Mhm.
When they aren't integrated, we see direct impacts on hemispheric function, depending
Mhm.
on the year of life where the deafferentation occurs. So our brain develops in sort of these 3 yearly cycles. So if we're having more issues within the first 3 years of life, it's going to be more of this like right side issues, then switches to the left, and so on and so
Mhm.
forth. So if we're having issues within like processed food, inflammation, infections, lack of movement, lack of sensory inputs within this time, then these reflexes can be retained. And that leads to poorly controlled movements throughout life, a lack of integration of the vestibular system, which is crucial for our balance, our sense of homeostasis, our ability to win the constant fight against gravity.
Yeah.
But it links to other systems throughout the brain. So the limbic system, our emotional center. What's your only unlearned fear? It's
Mhm.
falling.
Mhm.
So when this vestibular system is poorly integrated from these reflexive, this reflex retention, we've got a constant state of threat. And this is going to feed in and make more sense when we go into some of the pain neuromatrix models. But
Mhm.
threat is one of the things that moves our overall system towards a state of symptom, whether that be pain, restriction, headache. They're quite often threat responses where there's a total sum of threat that has exceeded a window of capacity of the system.
Yeah.
We not only have more things contributing to threat when these reflexes are retained, because we have alterations in movement, brain function, which feeds into the control of every physiological system, but we've also got an overactive amygdala. So another region of that limbic system, which drives like fear-based emotional memory,
Mhm.
where we not only have more inputs driving threat, but we have a reduced window of tolerance as well. So now every single minor stimuli is potentially threatening to these brains.
Mhm.
So we start to get very much so more chronic stress, our GI complaints. Pretty much name a symptom, we can see connections back to disintegration of reflex development. Dependent on that, obviously, there's bigger clinical picture there as well, but because of the alteration of systemic functions through left and right cortex being biased towards slightly different behavioral phenotypes,
Mhm.
we can see, dependent on reflex retention, hemisphericity, immune systems that are either more suppressed or overactive, a connection with the body that is present or not, emotional states of more approach based emotion or more withdrawal based emotion. So, very much like cognitive phenotypes, behavioral phenotypes, immunotypes, we can trace back to these imbalances in the brain, which all traces back to function, well, traces back to reflex retention being one of the ones we see most readily.
Mhm.
Reflex return is another one, which happens when there's a deterioration of the health of the brain. Because when health goes down, it reverts back to more reflexive systems. So these are your like neurodegenerative conditions, our strokes, our brain injuries, things of this nature, where we can see not necessarily a retention, but also a return of reflexes, which brings about the same or similar symptom profile and overall like process.
Wow. Okay. We need to have a talk offline because there's some questions I have for me personally on this one. So the other thing I wanted to bring up just quickly, because a lot of the people that are going to be watching this are going to be very, very familiar with the blue light blocking glasses. I'm wearing some right now. Now, in the evening, the first thing that people will be told to do from a blue light blocking glasses perspective is to wear the red ones. So obviously, if somebody is more in need of the, as you say, the blues, the greens, and the violets, you're in the evening right now and you're using violet. So I'm assuming that's the alternative swap out for the red light, I'm assuming. So if you are more stimulated by red in an evening, you should have violet. I'm assuming that's the kind of correlation.
Yeah. So there is like mixed research on the aspect of light in the evening that interferes with melatonin production and sleep. There's obviously some studies saying it's more the spectrum of light, others saying it's more the intensity of light.
Yeah, the brightness.
Yeah, the overall like how illuminated a room is. So if you're using dimmers, obviously we know that has less of an effect than if you're on like fully bright, harsh LEDs.
Mm-hmm.
Now, looking at it from a hemispheric perspective, in the simplest way of looking at things, it's your brain that's running everything. It's running every endocrine axis. It's running every physiological process within your body. So if there is a dyshomeostasis within the brain, we're going to have alterations to other systems. And if we can balance the brain, we're going to have a better regulation of our stress cascades, of our hormonal production, our melatonin production, our circadian cycles. So for me, it's very much so, can I regulate the brain to regulate these other physiological processes? So if I'm in the evening, right now in the office, I've got the lights that I can change color based on who I'm treating. So for me, it's going to be a purple on, or I will wear like purple lenses if I'm in the gym or if I'm watching TV or under artificial light.
Okay. And where do you get these purple lenses from? Is this like just from Amazon?
Yeah, there are some on Amazon. So Amazon's one of the places. Glow FX is one of the brands. So they do a lot of different colors that goes across the full spectrum.
Cool, amazing. I'm going to try some of these purple ones because I want to see what the difference is. Again, like you, I'm just the walking end of one experiment, so I want to try these things because I do notice in the evenings, red does subdue me slightly, but not as much as what it does for other people. So I'm just wondering if the purple lens would be more beneficial because obviously, as we know, melatonin is created through the day by getting light exposure. It's not the darkness that creates the melatonin, it's just the darkness that releases it. So if you are then, as you say, supplying the right stimulus, violet, purple, or red, the result should be the same theoretically if that's what your body's after. So I'm going to give that a try and see how that goes.
If you've set up your day to be entrained in a circadian way, then 100% like eating at appropriate times for your location on Earth, your seasons. If you've got sun in your eyes early in the day, ideally like sunrise and sunset would be ideal if possible.
Yeah.
Then just having dimmed lights and the lenses that are appropriate for your brain, I've seen way more benefit than anything else.
Yeah.
Similar to you, like blue light blockers actually do the opposite for me. So they wake me up to the point where I would deliberately wear blue light blockers if I needed to do more work in the evenings when I was getting tired.
Yeah. Yeah. Stimulating you more.
Yeah.
Interesting. All right. Okay. Reconceptualizing pain, the neuromatrix, and why understanding the physiological function is the foundation. Explain all this to me. What's the neuromatrix?
So the neuromatrix is a set of structures within the brain that modulate for pain, because pain is not a process of the tissue. It's an output of the brain. Now, when I say that, I don't mean to say that pain is purely in your head, because it is very much a physical process. but there is no receptor at the tissue level which encodes for pain. They encode for threat or the potential for threat or damage.
Okay.
That is then sent through the nervous system for the brain to compute, integrate, interpret, and then send out an output of pain if it's required. So a huge part of this neuromatrix is obviously how well developed is our brain? How well can we fire inhibitory systems to reduce pain? This, I'm saying this because it links back into those primitive reflexes. Because if they're not integrated, we lose some frontal cortex function to fire these inhibitory systems to inhibit pain. So we get exaggerated pain responses when these reflexes are present. So that's the pain matrix. And when we look at threat, it's anything that moves us away from homeostasis. Mm-hmm. So for me, a foundation of health is very much so the foundation of brain health. Because when we're looking at this, any aberrant function within our body can drive threat, whether it's digestive, whether it's hypothyroidism, anemias, anything of this nature is not only a disease or subclinical disease state in a functional medicine lens, but from a neurological lens, we're looking at it as a threat to the system, which can then drive these responses of pain as a modulatory output. Now, there is some hierarchical order in which I prioritize these. Basically, is in how impactful they are on brain health. So when we're looking at like disorders of mitochondria, disorders of glucose management, disorders of oxygenation, so our anemias and so on, our insulin resistance, hypothyroidism because of how it directly impacts nerve development, nerve growth. Mm. These are going to be some of our like tier one priority things. And then when we get into like maldigestion, malabsorption, and things of this nature, they're secondary.
Okay.
Because they're still important, but they just slow down recovery. They don't completely prevent it. Whereas our tier one systems, our lack of sleep is another one, because we can't drain inflammation, we can't drain waste out of the brain if we're not sleeping. And then if we're not sleeping, we accumulate more waste. So it's this vicious cycle. So it's very much, we have these tier one priorities that if they are present, these are the things I will address first. Then we've got our tier twos, and it's working on the improvement of all of these stages of physiological function. So not only do we have the foundational components of neurotransmitter development from like our B vitamin perspective and everything, but just from an easier conceptualized viewpoint, there's less threat in the body that the brain can interpret as my window of tolerance is full. I need to deliver a stimulus now to get this person to stop. Mm. Because it's so often, especially in chronic pain, it's modulatory rather than actual tissue damage. So obviously if someone's run into you, like you've been hit on a rugby pitch by someone huge, that's a tissue-based issue. Yeah, there's going to be modulatory components still there, but we treat that in a more acute scenario. But when it's these insidious onset, like you wake up with a crook neck, it's like, I don't know why it's feeling that way. Like so often that's an output-based issue rather than like you've twisted your neck in your sleep, because your body's more resilient than that. So that can be our vagal tone issues. It can be like more obstruction of the vagus nerve along its route along the esophagus. It could be referral patterns from the stomach. So there's multiple things we can look at in these neck tension. It can be referral from like poor breathing patterns, from diaphragmatic function. So there's different lenses from different methods of teaching where we can look at referral patterns and
Mhm.
see what is most likely driving these insidious components from a physiology perspective, but also what's driving it from a modulatory perspective, like what neuroinflammatory drivers are present.
Yeah.
So this is where it's tying like the nociception. So nociception is the stimulus that comes in that then the brain encodes and drives a pain output. When I teach, there's like around 20 different nociceptive drivers that I teach heavily on. So it's not just it's anything mechanical, chemical, thermal, emotional can drive nociception.
Mhm.
And then we're looking at the balance of nociception against endorphins, against opioids, against our chemical mediators as one pillar of pain.
Mhm.
But then another key pillar is, okay, how is the overall health of the brain to activate our descending inhibitory systems? Because it's those descending inhibitory systems that dampen the outputs of pain,
Yeah.
but also dampen the outputs of the sympathetics. Because we know if we have increased sympathetics, that drives pain itself. So we need these inhibitory systems firing. So we need to compare the health of the cortex, health of the brain, against neuroinflammatory inputs. So that's all of our, okay, what is the stage of neuroinflammation? Is this transient? So it's like, oh, I get a little bit of brain fog every now and again. Or I've got brain fog all the time,
Mhm.
which is that transition from more transient inflammation to chronic. And then it's getting into more of our glial primings, our blood-brain barrier permeabilities, where we're looking at more serious losses of function and specific
Yeah.
symptom profiles that can flare up. Maybe when you're exposed to chemicals, you start to get a headache. It's like that can be more of these like glial mechanisms where it's a stimulus that really shouldn't drive that intense a response.
Mhm.
But because that region is sensitized, now a lesser degree of insult drives a more extreme response. So we've got to look at dampening the overall level of inflammation down so that there is less of a response within those glia.
Yeah.
Now, how much we can bring that down is still very much unknown. There's likely always going to be hyperactivity priming of those glia.
Mhm.
So, so for me, it used to be terrible. Like if I had any impact to the right side of my skull or ate gluten, it would screw me. Like I ate a pizza and the next morning I looked like Quasimodo because it had inflamed my cerebellum so much it had torsioned my spine.
Oh, wow.
Um, and if I'd hit my head, I'd be written off for like, I wouldn't be able to focus for like 5 to 7 days. And
Wow.
you met Kaiju at the beginning of the call. So
Yeah.
he's about 40 kilos and his head is pure cement. He head-butted me um, recently. And
Yeah.
because I've done all the work, it's like, yeah, it wasn't pleasant, but an hour later, I was back to full focus.
Yeah.
So they're very much, it's not like a death sentence. We have scope for recovery if we can do the relevant work.
Yeah. I agree. And you know, this ties in quite nicely to something that we were discussing while we were chatting before the call, but also on our messages before we came on. Both you and I, obviously coming from that functional medicine background, have dealt with many people who will come to us and they're on like £1,000 to £2,000 worth of supplements a month, and they feel no better. They don't know what's working, and our goal is to obviously get them to a position where they only need the basics, because that's basically what we need to fill in the gaps with. It's like, what don't we get from our life? As an example, like magnesium, everybody's magnesium deficient. So, okay, so we need to make sure we've got something like magnesium. So this ties in nicely because so many people, like the guy that I was speaking about earlier, are supplementing or injecting their way out of a perceived pain, health issue, whatever the case may be. List is endless. So for everyone that's listening and watching, what Martin's basically saying here is we are very much physical focused in the physical manifestation of the thing that we are feeling, when ultimately this is predominantly a neuromuscular, neurochemical drive. And if we deal with that, we won't need to necessarily eventually spend that amount of money and take that amount of supplements, because our body is, in all intents and purposes, anti-fragile. We should be in such a good state of health, and physical health and neurological health, that whatever happens in life, the body can just bounce back. Give it some time and it will bounce back on its own, because the body knows what to do. The body knows the score. But we are completely bombarded with so many toxins and distractions and notifications and EMF and radio waves and different light exposures, and we're outdoor mammals living an indoor existence like in a zoo, that we are having to supplement our way out of these things. We're having to take on these wildly sporadic diet protocols, keto, carnivore, and I'm probably going to piss a lot of people off by saying that, but you don't have to do these things if everything is in alignment. It's when things, as you say, like left to right hemisphere, when things are starting to be out of sync, you haven't got that hemispheric syncing going on. This is driving that need to do these things, because we're not addressing the main issues. So I think this is where what you do and what we're talking about here now is such an understated and under talked about topic, which is why I was so amazed about like you coming on, because I was like, yes, this needs to be spoken about, because nobody speaks about this, is how much the brain drives this. Because a lot of people will say, oh, you know, got the gut brain axis and, you know, the gut's driving a lot of this stuff. True. But I think that the brain's driving a hell of a lot more. Now, I might be wrong, and you'd obviously be the guy to ask. So do you feel that there's more neurochemical stuff going on that we're not seeing and not addressing, compared to the gut side of things, like fixing the leaky gut, fixing all those other types of things, the dysbiosis and stuff?
Yeah, so obviously all of those are hugely important. But from my perspective, they fall into tier 2 function, because we can still improve while they're present. We can still drive a step forward in neural function when they are present. It's not going to be optimal, but we can still move the needle.
Yeah.
But if we've got these retained reflexes, or a disinhibition of the vagus nerve, for example, that's going to be reducing our production of gastric secretion, so reduced stomach acid. So now, I've got reduced bile, so I don't eliminate excess estrogen or toxins effectively. I've got reduced pancreatic enzyme secretion, so I'm not digesting starch as well. So now I get this buildup that leads to more of my small intestinal bacterial or fungal overgrowths, which then feeds into the leaky gut. I've got the lower stomach acid, so now I can't sterilize the contents of my stomach as effectively. So now I'm getting more pathogens coming in. So I've got parasites or candida or whatever it may be. Now, what's the initial output that's driving the release of those secretions is information from the vagus nerve. So if I've got a cortical dysfunction and I can't fire my vagus nerve effectively, I can do all the HCl, pepsin protocols I want. I'm just going to end up on them indefinitely, because you're not correcting the driver. Now, this is where in my eyes, it's very similar to you, where functional medicine interventions, generally speaking, now there are situations if someone's had like destruction of a gland, removal of a gland, where that is going to be a permanent intervention.
Yeah.
But a lot of the time, functional medicine practitioners now, it's just repackaged conventional medicine, where they're just replacing pills for like drugs for supplements. So it's just the polypharmacy model of conventional medicine done from a herbal lens, rather than actually looking at like what functional medicine to me is. Where is the breakdown in physiological function, and how can I drive an improvement in this function? Not just, this is the symptom, here's a pill to suppress it or try and change it. Like, where is the actual breakdown in function? Now, in that scenario I just gave, someone might have terrible stomach issues and not digesting or absorbing anything. So we're going to have to set up a dietary framework where they can digest the nutrients as effectively as possible. So this would be more, looking at their food choices. Like, oh, you've got low stomach acid. Can we use more like white fish and minces rather than eating a steak? It's probably not going to be the best thing for you right now
Yeah.
because you can't break it down effectively. Okay, you can't break down starches. Can we go more to a isocaloric protocol because you don't have effective utilization of bile, so you can't digest heavy fats, and keto is going to wreck you. So can we be more critical in our thought processes around dietary frameworks and food choices? And then from a supplemental perspective, yeah, we might need some HCl in the short term and maybe some pepsin, so some zinc pepsin in there to actually bring up HCl local to the stomach. But while we're doing that, how can I create this window in which to then integrate the vagus nerve? So I might be doing direct vagal exercises, your humming, gargling, transcutaneous auricular vagal stimulation, while also bringing up the integration of reflexes if required.
Yeah.
But again, it's what's integrating into our brainstem for the firing of like these cranial nerves, cortex. So does this person again have a right brain imbalance where I need to bring up the overall health of the right side of their brain, which can be sensory inputs, correcting the peripheral biomechanical presentations is a part of it, but also giving them like right brain specific stimuli based on eye movements, balance, colors, smells, sounds that stimulate that hemisphere. And then again, driving this. So we're looking at the functional medicine interventions with an end goal in sight of getting rid of them. Like my goal of any intervention is to get rid of the intervention as quickly as I can. Rather than having to use 20 different supplements and 10 different peptides as a badge of honor.
Yeah, I agree. It's not about keeping people on things permanently, because otherwise we're just lobotomizing their wallets permanently, which is not a good thing. It's about making them a CEO of their health, as I say to people, like, how can you be the one that's in control? And it's about teaching people as well at the same time. And that's what's good about what you do, is the fact that you're teaching people all of this while you're getting them to do it at the same time. It's not a case of here's a protocol, just go and do it, go away. Like, you're actually saying to people, right, this is why we're doing these things. We're going to put you on this for now, and that's going to help your body do these things while we address these things, which will then lead us to then you not needing these things. And then we can take them out and then maybe bring in other things that are more needed at that time. You say working through those layers. And I love this approach because I'm exactly the same now, where obviously everything was very functionally medicine driven before. Now it's a lot more kind of like, what's the minimal effective dose from a functional perspective that we can do? And what are the other more neurological things, lifestyle based things that we can do, which are cost effective or free to some degree?
Yeah, I'd still say I use functional medicine heavily. It's the baseline. It is everything I use within that scope of physiological function to form the foundation of how we have homeostasis or dyshomeostasis within the body. It's just, now this obviously isn't the entirety of the industry. There are loads of amazing practitioners.
Oh, there are, yeah.
It more comes across as to when people try and apply it themselves or don't have an end goal, can't reverse engineer the process with an end goal in sight, and don't have this understanding from the neurological lens of when it is a higher system issue. Because like in gut issues, some things will start in the gut, but everything will involve the brain. So it's like it may well start somewhere, but we have a process called retrograde chromatolysis, where if there is a reduced firing of a nerve, there is a alteration in communication, and it can cause central issues. So then we can start to get central degeneration based on this reduced firing of the peripheral components of the nerve.
Right.
So this is then how we can start to get some of these deafferentations where my cortex is losing function based on oh, I've got an impingement and I've trapped a nerve or I've damaged a nerve in, say, like my leg, or it could be a permanently inflamed liver. So we might have overactivation of Kupffer cells in the liver that drive this vagal communication and then actually drive central inflammatory processes, not because there's a problem of the brain, but because there's a inflammation of the liver from whatever it may be. But it's then, being able to take a step back and look at the big picture of the overall presentation and say, okay, like, you've got these brain symptoms, you've got these liver symptoms, you've got these emotional symptoms, you've got this right shoulder blade pain. Okay, like, your right shoulder blade pain is quite likely going to be referral from that liver, because that's a common referral pattern. Okay, now how do we address the liver? Because it started here, we're going to need to address it, but simultaneously, now that there's this vagal communication, we're also going to need to address some neuroinflammatory principles to improve central function. And we're likely going to need to actually do some vagal work to then drive improvement on the outward component of our vagal health. And this is where, like, so many people end up having to maintain the state of supplementation, because we can't out supplement a lack of activation.
Yeah. Well, I like that. Can't out supplement a lack of activation. I like
we
that.
Can't that out diet, out supplement, like, out medicine a lack of neuronal activation. So we have to, over time, and this is the same for whatever we might be thinking about from a symptom profile. Is it cognition? Is it pain? Is it movement disorders? It's whether it's inflammatory to start with or activation based to start with. Long term, there is going to be a component of both inflammation and lack of activation that maintains the state of pathology. Because if it starts at inflammation, what's the first thing people do when they start getting a symptom, or they start getting a brain-based symptom especially, is they stop doing the things, or they stop using that part of their body or brain. So then we stop using it. It's a use it or lose it mechanism. It starts to deteriorate. On the flip side, if it starts as a lack of activation, then the health deteriorates. So then when they do use it, it's closer to its firing threshold. And when it exceeds that, it can drive inflammatory processes. So it's very much a state of, like, yeah, we're going to have to correct the inflammation, but then we also have to fire a nerve at a rate that is according to its total state of health and progressively overload that over time. Much like we would any other training stimulus, it comes down to finding a threshold of activation that we can safely do that doesn't cause symptoms, and then progressively overloading that over time.
Love it. Love it. Okay. Next up, we might have already covered this one already. Pain and brain inflammation.
Yeah, I think we've gone through that enough.
Yeah,
actually.
I think so. I think so. Okay. Pain and fatigue, energy production.
Yeah. So what I was just saying there, lack of activation. What's a requisite of firing a nerve or doing anything within the body? It's energy production, isn't it?
Right.
So I cannot derive any physiological process I need to do if I can't create energy. I can't heal any tissue within the body if I don't have energy. I can't overcome a suppression of my immune system and actually drive requisite cytokines to kill an infection if I'm not getting ATP. So from a most simple perspective, it's looking at, okay, how is your state of energy now compared to 1 month ago, 1 year ago, 5 years ago? Is it on the decline or is it increasing? And can we actually track your energy over time and look at, is this correlating to an increase or decrease in your overall resilience? Because we know as resilient as mitochondrial health goes down, so our foundation of energy production, resilience goes down. And then ultimately, what is the foundation of building mitochondrial health is bioenergetic challenge.
Yeah.
So fasting and periods of like lower calorie consumption, all of the things that are going to inflame mitochondria are Western lifestyle, hypercaloric diet, processed foods, lack of movement, lack of utilization of the brain.
Mm-hmm.
So this is where it all ties back into the brain and pain, because if we've got these lack of energy states, lack of neuronal activation, lack of neuronal activation could come down to a lack of ATP production. But then also, when I'm not firing my brain, I'm not improving the health of my mitochondria. So again, then it starts to deteriorate our ATP production. So it's looking at this tying in all together. Is it's not just, oh, I need to focus on pain, or I need to focus on energy production. It's okay, this glycemia thing that we were talking about in neuroinflammation is also huge in our mitochondrial health. So do I need to actually correct your energy systems in order for you to fire your brain better? Quite possibly, because when I'm at a resting state, if I can't effectively go through oxidative phosphorylation, so our mitochondrial cycle of energy production, my neurons are going to be focusing more on glycolysis. You still there, mate?
Yeah, I'm here.
Is it okay? Sorry, it's a terrible storm. I don't know if my internet's holding up.
It's doing well.
So if I can't utilize oxidative phosphorylation, my neurons are going to rely more on glycolysis to fire and get enough done, but this can't sustain them, because rather than that like nice high amount of ATP we get from oxidative phosphorylation, it's a very low amount from glycolysis.
Yeah.
So it fires a neuron temporarily, but it can't sustain that firing, and it starts to close the gap between resting potential and threshold for firing, and it actually exceeds that and then starts to deteriorate in health, drive these inflammatory processes. So this is why, like I said, glucose and oxygen are so crucial, and they will be two of the foundational things that I will look at for brain health. Like, how are your glucose pathways, and can you oxygenate your brain and body effectively? So this energy production is absolutely critical. I know this is a key area of yours as well, looking in like, okay, how can we actually drive mitochondrial health? So the whole circadian entrainment to lifestyle is huge for our brain function, because like you can't fire neurons, you can't heal if you can't make energy.
Yep.
But we're looking at I've talked about it from a pain perspective and an ATP perspective. If I don't have ATP, my nociceptors are closer to threshold. If I don't have ATP, my brain function is down. My brain endurance is down. So now I can't fire those inhibitory systems to dampen my pain or dampen my sympathetics.
Yep.
If I don't have ATP, I've got reduced blood flow to the brain, because it's a pump mechanism that is still going to require some energy to initiate.
Yeah.
So now I've got less oxygen. Okay. My brain's more inflammatory. I might start to get microglial priming or other states of neuroinflammation, which again increases pain. I've now got decreased immune cells because they require ATP as well. So now I've got an increase in systemic inflammation, which is one of those nociceptive activators, which contributes to pain, but it also contributes to neuroinflammation. So now I've got all of these different things driving the state of pain. I've got increased glucose demand because it's the only thing my brain can use for energy, because it can't enter into oxidative phosphorylation. So it's firing off all these glucose. So now I'm going hypoglycemic, not because of a deficiency in intake, or sometimes not even because of insulin resistance, but just because it's the only fuel source my brain can use. So I'm actually getting cerebral hypoglycemia because my brain is running out of glucose, because I can't actually enter the Krebs cycle effectively and actually support its ATP demands. And again, obviously that drives neuroinflammation and it drives pain sensitization.
Dude, this is fascinating stuff. And I think for anybody that is sat there thinking that went way over my head, let me put it into words that I'm understanding right now. Ultimately, for a lot of this stuff to be happening, it requires energy. Our body's energy currency is ATP. ATP is one of the productions of the ATPase through the mitochondrial transport chain. Mitochondria are what make all this happen. And so therefore, if you're not doing things which support your mitochondria, as Martin is quite rightly saying here, pain will increase, healing can't happen, inflammation gets overdriven, everything starts capitulating and falling apart. So in all intents and purposes, the brain and the mitochondria are intrinsically linked, and the mitochondria are anticipatory in nature. They anticipate things happening before we've even had the ability to process it. So they are always on the watch for what's happening. And if we're not treating them properly, and if we're not doing the things correctly to provide them with the resources that they need, everything else is null and void. Nothing's going to work. Nothing's going to help. You know, for people that don't know, I have just had reconstructive surgery done on my right arm. My first state of play wasn't, okay, so how do I make the bone heal faster? How do I make the inflammation go down by taking anti-inflammatories? It was like, right, before I go into surgery, I'm going to be priming my mitochondria before I go in. I'm going to be giving them all the resources that they need. Then on the day of surgery, I bolus dosed everything. Then when I came out of surgery, I didn't sit there with all the foods that I wanted to eat after surgery. I was taking all my mitochondrial support supplements so that my mitochondria could recover from all the EMF, all the poisons that were put into my body to help me survive the surgery, the anesthetics and the antibiotics and all the other types of things. And then when I got home for the first week, I was just basically focusing on how do I heal my mitochondria. Everything else has then just been layered on top. Now, what can I do to support the bone graft healing? What can I do to reduce inflammation in my arm? But ultimately, if I give the mitochondria what they need, they will do those things anyway. I'm just going to be giving them a little bit more of a helping hand. This, to me, has connected something which I hadn't actually thought about, which was how important the brain and the mitochondrial connection is. I hadn't actually thought of that before having this conversation just now. So I would like to ask you, from a tier perspective, how important is that when it comes to how you work with your clients? Is that a major focus for you?
Like mitochondrial bioenergetics is like primary tier one. So it's like I think I said earlier, like mitochondria, thyroid, glucose, oxygen, lack of movement, lack of sleep would be some of the primary areas of addressing. And if you're not getting those sorted, like, again, it's going to be the same. If I can't produce energy to heal, I'm not going to resolve my leaky gut.
Yeah.
And it's even more apparent in brain issues because the path that the mitochondria have to take, the mitochondrial transport systems within neurons, is longer and more complex.
Yeah.
It actually gives us a brilliant window in which to use brain endurance and brain health as like a mitochondrial litmus test, because it will show up mitochondrial deficits in the brain sooner than it will in other areas.
Interesting.
So we can very much so, when we understand the like fatigue rates and so on within specific neuronal pools, we can start to say, okay, there's more of this global reduction in energy production within the brain. Is this because, you know, it might be injury, but quite often when we're seeing it more global, it's metabolic in nature. So when it's metabolic in nature, it's like, okay, let's go through these checklists. Is it glucose? Is it oxygen? Is it mitochondria? Is it thyroid? And then starting to see it like, okay, for this person, like they're sedentary, they're in a hypocaloric diet, they're bombarded with light and EMF, and they haven't seen the sunrise or sunset in God knows how long. Like, we probably need to address mitochondria before we really start trying to ramp up anything else, because it's just going to drive more inflammatory processes if I try and fire their brain when they can't enter into oxidative phosphorylation effectively.
Yeah.
So it's very much like so many moving parts within the model, but it's when you can start to see these like you just saw then, it's like, oh my God, the penny's just dropped on this pattern. And now I see that connection coming in here. And it makes
Yeah.
so much sense as to how this is so critically important.
Yeah. Yeah. Massively, dude. It's insane how much that. And again, I hadn't made that connection. So I'm very glad we had this conversation, because that's opened up a door where I'm thinking, when I finish talking with you today, I want to go and do some research on this. Or I might just have another call with you, which isn't recorded. We can discuss this even more. So one last thing, and then we're going to close out on this one, because again, I want to be very careful of your time, so it's late for you. Practical neurology for the gym floor, brain imbalances and all those types of things. A lot of people listening to this are going to be gym goers, and they all want to know how to build muscle, lose body fat, and all the rest of it. So practical neurology for the gym floor.
Yeah. So this is a little harder to give specifics, because like I said earlier, everyone's individual neural maps is completely unique. But some areas to start looking at that people typically don't view is, like I said earlier, treating the side of the body can make your symptoms worse if it's neurally driven. So if you're anyone who has a history of like brain injury, concussion, traumatic birth, anything of this nature, or you had like traumas, infections, illnesses within the first 3 years of life, and you've got a chronic pain, start thinking that I might have to do some reflex work as a foundation to then improve muscle tone globally. Because when we go into the neurology around muscle tone, my right cortex, as I said earlier, is responsible for the right PMRF. Now, this right PMRF is going to regulate muscle tone on the right side of the body. But what it does is increase extensor tone. And when we lose this, we basically get an asymmetrical presentation where I have global reductions on my right side, but I've got larger decreases in my extensors than my flexors. So now I've got a flexor bias in the upper limb and a extensor bias in the lower limb, because the tract flips over at the level of T6 in the spine. So we get this shoulder that's turned in, a leg that's turned out, but all of the muscle tone is turned down on that side.
Yeah.
And we start to get more tendon issues, because tendons are from muscle deconditioning, effectively putting it most simply. So now we start to get all of these chronic tendon issues. Like people in the gym going, oh, I've got this chronic like shoulder thing, I've got this chronic elbow thing. It's like nothing's making it better. Like start looking at the health of your brain. We might need to change how your brain sees information to make that output to the muscles better, because sensory always precedes motor.
Okay.
But it's always sensory, then the integration, then the output of motor.
Yeah.
I've had bodybuilders who have had 7 years of chronic bicep tendon pain resolved in, I think it was about 3 minutes from giving them blue lenses, integrating the 3-4 reflexes they had with specific exercises, and then doing some more like integrative cerebellar work so they could map their joints more effectively, and a little bit of load tolerance work on the arm so they could actually utilize their hand from a distal force tolerance perspective.
Yeah.
And it's like curled, it's like go pick up a weight to curl, and they're like, yeah, there's zero pain. Like, so there's like, okay, 7 years of like physio and doing everything around it, there's still tendon pain. It's like nothing had ever got it down to a zero. It's like, and then a year later, they're still completely pain free. You have nothing going on with it.
Wow.
Because they carried on utilizing the same principles. Like, okay, I'm going to integrate these reflexes for the intended course. I'm going to use this sensory stim of the blue lenses when I need. I'm going to improve my distal load tolerance. So every time I'm interacting with the world with my hands, I can actually absorb that force rather than it transmitting up, and now I'm getting elbow or I'm getting shoulder issues or whatever it may be. So that's one part. The other things I would say are look at your vision. So like at a foundational level, see if your eyes can coordinate when they're coming in. So video yourself doing it. Can your eyes track together coming in? If they don't, every single thing within your environment, the image that your brain is seeing is different to what you're physically picking up. So now there's likely to be subtle postural shifts and errors, because if I go to pick up a glass and I've got a lazy eye, the intended movement plan my brain sends to my arm is different from the mechanical feedback that I receive, because where my eye is mapping it, where my hand is mapping it, and then what my brain initially intended doesn't match. So now there's going to be subtle postural deviations based off the mismatch in information. So track your eyes, see if they can coordinate in together. If they can't, cover the good eye and start to track the lazier one across, just so we can start to improve some binocularity of vision. Now, that's going to be a very, very small percentage, but without individually assessing people, I can't really give generalizations.
No, it's difficult to do. You're dealing with a very complex situation.
The other thing would be stand with heel to toe. And when you are able to maintain balance and maintain fixation on a fixed point in space to get your balance, close your eyes and see if there is a deviation off to a side. That's going to indicate, generally, there are some, again, rules that negate this, but in the vast majority of people, this is going to be the side of weakness of the vestibular system. So a side where the cerebellum isn't reporting on gravity as effectively. So if we start to do some more rolling or spinning patterns to that direction, then that can be a way to train the cerebellum, train the vestibular system, upregulate the brain, and incorporate better balance. Now, this, again, can bring up that tone of the muscles effectively. So this could be, okay, I've got these right shoulder issues, but I fell to the left. Understanding how the brain works, this is a function of my left vestibular system, left cerebellum, which is right cortex. So maybe this is the reason I can't regulate muscle tone too well on my right side of my body. Maybe I'm going to do some leftward rolling patterns before I do some upper body work and see if that changes this pattern. And then it could be, you know, progressed over time where it's now, okay, I'm going to do some leftward rolling patterns, but as an arm bar. So now I'm starting to get a bit of loading behind it. So I'm integrating some biomechanical aspect into the neurological drills. Or sorry, into either way you want to look at it, integrating neurological principles into the overarching thought process behind some of our more biomechanical drills. Either way you want to look at that works. But it's very much where we end up blending neurobiomechanics so we can get more targeted output from an exercise. Or the other way of doing it in earlier days is quite often going to be utilizing our neurological interventions as like warm-ups or like feeders between sets to bring function back up, just making sure, again, you don't exceed your own tolerance. But then as you get better at it, it ends up being like, okay, how can I train these specific eye positions? How can I train the ability of my eyes to move together in a more athletic manner? So it might be doing vision charts while doing a plyometric push-up, for example. Just the integration of these more neurological based derived principles into our biomechanical interventions. But yeah, I can't those would be the two that is easier to actually say and do. But if I'm looking at like the entirety of my model, it'd be physiological function. It would then be going through gait assessments to determine a primary pattern that your brain is presenting as. And then each of those primary patterns has a systemized framework in which to go through, which for hemisphericities has like 13, 14 different components where we're going into, again, tiers. So tier 1 is restoring safety. But if you're this hemisphericity, we need to restore safety first, which is physiological function. It's integration of reflexes. Emotional imprints comes into a huge part of that. And I say emotional imprints because not every emotion is a trauma.
No.
So, but it can still have a impact on the system, even though it wasn't derived from a trauma. It can still be a traumatic memory, even if it wasn't stemmed from a trauma.
Yeah.
Because we have this amplification within the emotional brain where it increases the intensity of stimulus as a protective response. Because we have that inherent negativity bias, because positive emotions don't help you live. Like negative emotions and knowing when something's going to kill you or damage you keeps us alive. So the brain will always prioritize the remembering of negative stimulus.
Yeah.
And then also within this like safety component, we have nociception. So is there active nociceptive input? Then we sort of veer more into the dynamic section. And again, I say then it's not this clean. There's huge overlap because it's all interconnected. But dynamics is where I'm thinking about how can we connect the right to left side of the brain more effectively? Do we have any cranial nerves that aren't functioning? How is our pressure management system? So this is lymphatics and respiration and blood flow. Then we're looking at like neurobiomechanics. So this is our peripheral nervous system. This is our musculoskeletal system. And then it's getting more into like the integration components. So how can I actually now start to get these systems in a more coordinated manner that it's leading towards more performance rather than rehab. So that's very much the like very brief way of looking at it. So it's again a lot of moving parts, but there is very much like a systemized manner in which we can look at a body and go, okay, these are the highest order principles: reflexes, nociception, emotion, physiological function. Okay, there is a level of safety now that the system isn't in a constant state of driving autonomics. Because again, it's like these people go straight to like, yeah, respiration can be obviously is hugely important. Again, lymphatics, hugely important. They sit in tier 2 of my models. Because again, what's regulating these systems? The brain. Now, like we can drive safety from both of these. So I still utilize them in early doors, but it's understanding that if those central factors driving autonomics are present, there's going to be constriction of the lymphatic vasculature. So I can mobilize lymph, but it will reconstrict.
Yeah.
Because we've got autonomic activation actually just constricting vessels. I can do all the breath work I want, but if the underlying aspects driving a increased autonomic state are still present, I'm still going to revert back to more hyperventilation. Even if I can, do all the Wim Hof, do all the deep, slow breathing, and actually get myself grounded during, that might not necessarily be enough of an intense stimulus to drive the long-term potentiation of these autonomic centers within the brain that actually regulate the long-term change in behavior. So there might be a behavioral input that you have to repeatedly give, but what we strive for is creating a stimulus that is of high enough intensity to create a genetic change in the brain and drive long-term potentiation to increase the firing of a region so I don't have to do the daily shit anymore.
Yeah.
Now, obviously, it's a process of doing the stuff over a period of time to get to that level, but it's the same as we talked about with supplements.
Yeah.
The whole goal of the protocol is to not have to do the fucking protocol.
Yeah. That's exactly it. It's learning what to do now so you don't have to do it later.
100%.
All right. Which leads us into the final point that I want to bring up here. So everything that we've been talking about today, I would say 99% of what we've been talking about today, for people that are sat here like, wow, this is a lot to take in, you actually have all this in a course, which is fantastic. So the format, the content covered in the course, how's that all set out?
It very nicely mirrors what we've gone through today, actually. So it's a pretty extensive course. So the first few modules are more of a background around pain neuroscience, going deep into the neuromatrix, but going deeper into the functional medicine lens as well. So for each of these nociceptive drivers that I talk about, there is a complete breakdown of the physiological pathways of these. So then I know, for example, if I'm driving one of these nociceptive activators, what secondary and tertiary cascades it also activates that drives other nociceptive activators. So, for example, if I've had a recent injury, like Mark, for example, surgery, thinking, okay, like this could potentially drive neurogenic inflammation. It could also potentially drive histamine. It could drive activation of mast cells. We're going to have an increase in prostaglandins. So then from a health perspective, do I want to be directly implementing foods or interventions that increase histamine or increase prostaglandins or drive an increase to local blood flow in that area? Because we've already got more of a dilation of vessels local to that area that's got an increased import of cytokines. So do I necessarily want to increase things? Maybe not. So it's the understanding of this from a nociceptive level, then going into all of the neuroinflammatory components that we talked about. Again, breaking down all of the different neuroinflammatory drivers, the stages of neuroinflammation, the intensities of neuroinflammation, the understanding brain-based symptoms of mitochondrial deficit, going into energy production and pain. We're going into the role of inflammation and pain and also of fatigue and of brain inflammation. So looking at it as to the majority of people look at the endogenous drivers of inflammation. So, okay, I'm going to remove this food, I'm going to remove this, but never correct the internal state. So it's that balance between how can I correct internal state and also correct the lifestyle factors that fuel the fire of inflammation. It then, once we've got all of that background theory and knowledge, breaks down the clinical assessment and clinical interventions for all of these factors and has the practical components that I cover in my 2-day live workshop recorded and in there as well. So this is breaking down those gate pathways and a model of assessment and intervention for all of those 4 primary neurological patterns that we'll see from watching someone walk. So it breaks down all of those. And then for those who are super nerdy like me, there is a more in-depth mentorship as well, which takes everything from that practical strategies and goes 10 times deeper. Wow. It's really going even more nuanced on the context. So we can get into the specifics from a seminar case study Q&A component in actually breaking down the fun stuff, the stuff that I find more fun, which is the more complicated issues.
Amazing. Brother, I have got so much that I need to integrate from this conversation. Like, you've actually blown my mind with so many things. And I will be really, I listen to all my podcasts anyway. Not that I'm vain. I like listening back to things I might have missed, but I will definitely be listening to this again. And we definitely need to be jumping on a separate call just because I want to talk to you through some things for me as well, just some stuff that you've been talking about. I smiled when you said about the internal rotation on the right joint, a right shoulder, and external rotation on the right leg. I was like, that's me. So we definitely need to have a conversation. But for people to reach out to you, to find you, to look at your course, all that kind of stuff, where can they find you?
So Instagram is going to be obviously one of the easiest places. So it's the pain teacher _Martin. For the rewiring pain course, it is go.thepainteacher.com /rewiring pain. And that will give you more information about actually what's included in all of the modules, goes into it a bit deeper. But obviously, if there are any questions on any of that, do reach out to me through Instagram, and I'm happy to go over more in-depth answers as to anything included.
Yeah, amazing. And I'm assuming you're taking clients on at the moment. So if people do want to come and work with you directly, can they just reach out to you on Instagram as well?
I have a very limited intake of clients. I am still working with clients, but the majority of my focus is now on coach education, practitioner education. So I keep my one-to-one client work very limited. There are a couple of spaces at the minute, but they won't be available for too long. So if there is interest, do let me know, reach out for that. But I won't make any promises as to actually being able to take people on for the foreseeable.
Yeah, understandable, dude. You've got a lot going on. I'll pop all of that in the show notes below, all the links, all the Instagram stuff and everything like that. Plus the whole description of Martin will be in the show notes as well. Brother, thank you so much for sharing your knowledge, your extensive knowledge, your time, sharing your story with the listeners and the viewers. There's so much value here. Guys, I really hope that you rewatch this, take notes, reach out to Martin, check out his course. And Martin, thank you, brother. I really do appreciate you for sharing your time with me this evening.
No, been a pleasure as always, mate.
Always, brother. Okay, friends, this has been Martin Fenn, the pain teacher. This has been episode number 15 of the Decentralized Health Podcast. Please like, share, and subscribe and do all that beautiful stuff. And until next time, stay blessed and stay well.